It is my privilege to introduce Dr. Valerie Kanter. She's an integrative endodontist practicing in Los Angeles, California. She graduated from the University of Florida College of Dentistry with her DMD and MS degree and has been awarded diplomat status with the American Board of Endodontists. Dr. Kanter advocates a patient-centered biological approach to endodontics. She's a trailblazer in the adaptation of stem cell and laser technologies as a more natural and chemical-free approach to the treatment of root canals. She is at the forefront of the very latest research and studies on regenerative endodontics and less invasive laser therapies to provide patients with the best care her specialty affords. Dr. Kanter is a global mission to integrate her unique qualifications and experience into effectively fostering positive social and wellness changes. She works alongside the executive director of the Fluoride Action Network, a nonprofit organization on a mission to broaden awareness about the toxicity of fluoride compounds among citizens, scientists, and policymakers alike. I have the privilege because Dr. Kanter came to me quite some time ago and said, "You might not like what I do root canals." But I've done some really exciting things with stem cell. And I have to say, after reading an article that she published this last year, she is amazing. So let me again introduce Dr. Valerie Kanter.
Thank you, Dawn. Yeah, about a year ago I walked up to her booth and I think she about fell off her chair when I told her I was probably the only endodontist at that meeting. So I told her about some of the procedures we're doing in regenerative endodontics. She got very excited. I wrote the paper. I don't know if you guys have read it, but it's on, I believe that they put it on their website, and there's a similar version in the HDA catalog that Roberta has, and I'll be speaking there, kind of just like a follow-up lecture in Chicago as well in April. So let me tell you a little bit about myself, and I want to thank you guys for coming. Controversial subject of endodontics, so I appreciate you guys coming in here with me, despite how you may feel about the field. The only thing that I know is that I really know nothing at all. So feel free. I have a lot of information. I'm going to talk really quick and try to get through. If you guys have like a pertinent question, throw it out. I'm happy to do that unless it starts to slow us down too much. Also, you guys can email me, info@askdrval.com, any questions, or if you guys want copies of slides. I put some protocols on here for you guys when you're doing your vital pulp therapies with ozone and all that. So I'm happy to just send those to you because I don't want to spend too much time on some of those lengthy, wordy slides. So getting into who I am, where I am. I'm lucky enough to be in Los Angeles, California. It's beautiful, palm trees, warm weather. I have a practice in Beverly Hills with an amazing periodontist and also a private practice in Encino, which is in the valley, just over the Hollywood Hills. So it's pretty awesome. Key component, obviously, is this bad boy here out of Germany, the Zeiss microscope. It really makes a huge difference. So obviously CT scans are crucial. This is a picture of me at the private practice in the bottom right. That's my dad in the middle and my uncle Jimmy, both dentists. So I'm a third generation dentist. They're both in Florida. Fluoride Action Network is actually what brought me here to see you guys. I'm a baby in this biological world, but about 2 years in. And fluoride was actually what brought me here. Fluoride through ozone, and I just kind of figured everything out on my own. I was just full throttle in dental school doing exactly what I was told. And yeah, so we all know how that goes. I teach at UCLA. I'm slowly trying to integrate our concepts in there very carefully. It's tough. If anyone needs to do that mercury, reading, I guarantee this is a great place to get a really high reading. So you always have to be careful teaching there. Went to University of Florida. On the far right, you'll see this is a Jamaica mission trip. So I still go back and go with them, and we do extractions, and they actually open a dental clinic as well, so we can do treatments. And in the middle, Mouthpiece Movement, that's a nonprofit that I'm starting. Hopefully in the next decade, you guys will hear that name more, but the concept is to get a toothbrushing educational program in K through 5. So if anyone wants to help out or participate. They've been doing it in Denmark and places, and it's worked phenomenally with no chemicals or anything added to the water. I'm a big philosophy junkie. I almost minored in it until it got really intense, and then I just focused on the science in school. But this guy is just incredible. Alan Watts, I could listen to him every day. So he's all about bridging the gap. And I'm not talking about this gap. I'm talking about ancient, modern, functional aesthetics. You know, what we're all doing. We're trying to use science, and we're trying to use this other thing that exists that we can't really see, but we know it's there. Okay. Alan Watts. He's incredible. Tons of YouTube videos on everything. It's just an amazing man with a great brain. So we have like the true anatomy of what teeth look like, and then we have obviously this kind of social view of what's nice. We've got the ADA, all of these different organizations, equipment, everyone kind of telling us what to do. So we have to figure that out on our own. So this is one of my favorite quotes by him. Trying to define yourself is like trying to bite your own teeth. And I have a short clip of him speaking.
Because it's so mysterious. It's so elusive. Because what you are in your inmost being escapes your examination in rather the same way that you can't look directly into your own eyes without using a mirror. You can't bite your own teeth. You can't taste your own tongue, and you can't touch the tip of this finger with the tip of this finger. And that's why there's always an element of profound mystery in the problem of who we are.
So I graduated from the University of Florida. I was there for 10 years, and I shortly after became board certified, which was quite a process. We had to do extensive literature reviews, 90 minutes of oral exam, and every single answer that you gave back, you had to have at least 1 or 2 quality, peer-reviewed, and usually you would want to get those systematic reviews papers to back up what you said. So it's quite an intensive process. So anytime you see board certified, definitely that's a great thing. Then I met all you guys, and I got really confused, and I was like, what am I? I went through a bit of an identity crisis. I was very depressed. I think someone put me in tears at my first ozone meeting. So it's been a journey, so go easy on me. Don't throw any tomatoes up here. And I was actually supposed to be named Alice, but I was born on Valentine's Day, so my mom flipped it. But I felt a little bit like Alice.
I hardly know, sir. I've changed so many times since this morning, you see.
I do not see. Explain yourself.
I'm afraid I can't explain myself, sir, because I'm not myself, you know.
I do not know.
Exactly. Okay, so some quick objectives. We're going to talk about anatomy. We're going to talk about the PULP-DENTIN complex, principles of degeneration, regeneration, a little bit on stem cells, and some just kind of new alternative concepts. All right, I want to see hands. How many of you would extract this tooth right here? Don't be shy. I know you guys. That's it? All right. Well, why not? This is actually a bar in Thailand. Last year I went on a sailing trip with my sister, and although I wouldn't recommend any of the bottles on the shelf there, very dangerous in Thailand, the karaoke was awesome. Kind of having flashbacks to that moment right now, but why not? So let's talk about why not. Well, this is an incredible micro CT from Brazil that I got courtesy of Dr. Rico DeVito, and he was a lot of his slides are in here and some information, so I'll try to give them shout outs, but we'll just keep moving. So I want you guys to watch here and just try to see what you're looking at.
The heights by great men reaching that cavern were not not attained by sudden flight. But they, while their companions slept, were toiling upward in the night.
All right, I'm going to play it one more time for you guys because it's that cool. So as you go down into the apical areas and you're slicing through in this coronal fashion, you start to see these little dark areas just pop up everywhere. Those are isthmuses, those are lateral canals, those are these little anastomoses. And I mean, how in the heck is anyone supposed to clean all of this? Look at that. I get it. I get it. Okay? But not all root canals are created equal. I really, really wanted to take the moment for you guys to look at this slice. I see this all the time, and it correlates with this. Upper maxillary molars, every time. They miss the MB2. So when you guys are looking at these CTs, if you see this area of gutta percha is off center, there's a missed canal, and it doesn't just have to be in an upper root. Now, you don't always see the dark dot here. It may just be opaque, but it's so common to see it. And, you know, they think they got everything. And it's like, nope, you didn't. And that's just an entire canal. Think about all the stuff that we can't see, right? So this is a good friend of mine. Poor soul, she came in to see me. She had to fly from New York because she went to the wrong person after a trauma. And they, not only did they leave a ton of bacteria in her tooth, but they filled the entire chamber with gutta percha, left pulp horns, and it was just a mess. And so I'm helping her out with that. This is a nice case I did. You probably, I don't know if you can pick it up, but there's a cool little lateral canal here. Now look down here. I mean, you see this in a CT scan. Of course this is failing. Of course this is a focus of infection. They got completely off track in the canal. There's tons of anatomy missed if you look to the left of the gutta percha, so that's called a transportation, okay? And then in this upper one, you see, I mean, we can see some crazy anatomy in these. You can see sealer in here. I thought you guys would love that. You guys know what that is? Amalgam retrofill. What were they thinking? What were they thinking? So that's for sure mercury toxicity there. So this is just some more anatomy. I mean, this is what we're working with. I live in a very small world of tiny caves, and it's crazy. It's crazy in here. But we are able to get some cool things happening in these canals with some of the new technology. And I'm going to really quickly talk about that and then get into the regenerative stuff. But this is a nice 3D rendition. And then you can see here, this is a case I did and actually kind of matches that one there. Now, what the heck is this? I don't even really know what to say. Rico DeVito gave it to me and like chuckled. I just want you guys to keep in mind, you know, you see a lot of crazy stuff coming in your office, like you're putting mercury in these patients' mouth. What are you guys doing to the traditional dentist? But they're seeing this. And this patient said, well, my acupuncturist put all these gold pins. So we really have to just keep an open mind and always treat patients as an individual and do our best. Gosh, I have so much respect for Weston Price. I'm still just diving in and starting to read some of his stuff. I'm very grateful for all the work he did and how important that was in inclusion and understanding the development of humans. But I guarantee this man has never seen anything like this, okay? When he was doing his studies, root canals weren't able to do, root canal procedures, we weren't able to do what we're doing here. Watch very closely. This is movement of solution that's stimulated by a laser technique, a very specific laser technique. Not any laser can do this. It's one, and it's a specific tip. But you guys may not be able to tell, but at least 10 little white areas are popping up all over that apex. Okay, and that's not, no instrument has touched that tooth. And that's the kind of fill you're gonna get. That's pretty cool. This is another example of the kind of fill you're gonna get. And you asked me, all right, Dr. Val, you got the lateral canals filled, but like, what about these tubules? There's no way you can get these tubules clean. Well, we can. I'll tell you guys how. But these are an example of just perfectly intact tubules. And what are you going to fill them with? Gosh, this looks like an odontoblastomas. These are resin tags from a root canal sealer that's available. And it's so hydrophilic that it will just get sucked into the tubules. And these things up to 1,500 microns long, which is getting pretty close to the PDL. Okay, so pretty cool. So I ask you again, would you save this tooth? Well, we know why not. We've got our focal infection theory. And it's just so funny, like, I have flashbacks of my first or second lecture in residency, and they like just smashed the focal infection theory. This is not true. They made sure they got that in our heads immediately. And it's just funny, like, thinking back and kind of seeing everything. But there's obviously something going on with this, right? Yeah, it may just be this chronic area of inflammation that creates like a dysregulation in our extracellular matrix and this like acidic, really positive charged area, okay? I want to take this moment to give a shout out to Dr. Phil Malika. So he assigned this reading to me. I'm taking his integrative dental course and it's phenomenal. Like, if you love yourself, take the course. It's so good. Okay, so I actually got this information from that, which was pretty cool. And then I just, I'm thinking back to some of the papers I used to quote. I mean, think about bacteremia. If you're doing an extraction, like up to 100% of the time, you're going to see bacteria. Now, this is transient, but our body's able to deal with it, and the root canals was much lower. And this is, like I said, they took blood samples like right after the procedure. So it's a pretty classic study. But I'm with you guys. I get it. Okay, I just want to make that very clear. Bacteria, that's another reason. We've got all of these guys partying down in these teeth and having a good time. And we know that a tooth that's not alive is not going to be able to fight off these bacteria. We've got their toxins. I've read all of Voles' stuff and everything. I mean, I don't know it all back and forward. I'm going to be honest with you guys. I'm doing my best. I'm learning as much as I can every day. It makes sense. You have these kind of necrotic areas, maybe around the PDLs, especially if the teeth weren't cleaned out properly and you have all this junk in the tubules and it starts leaking out. You're biting on the teeth, you're chewing, toxins are moving around. I have to ask though, if I can guarantee the tooth is sterile on the inside, really the only thing I have to worry about is like that CEJ area, right? We have the cementum on the root, nothing's getting through there, down in the bloodstream maybe. I don't know, you guys may disagree. So we have the CEJ and all this like scaling and root planing every 6 months or whatever, just scraping those CEJs and opening those tubules up. So then we're dealing with periodontal bugs. I'm working on the research, you guys, just bear with me, okay? Obviously we have interference fields. So we've got these scar tissues that build up, and whether there's a lesion or not in the x-ray, we know there's a scar. You amputated a nerve, okay? And even if the bone grows back and the ligaments are healing, I mean, I have a scar on my ankle. I had a surgery. I regret it now, but I had it, and it's a little swollen, and I know it's an area where there's a problem. The meridians, I get it. I've seen it firsthand, too. So a good friend of mine, his wife, he's actually my research partner now, and the inventor of PIPs, which I'll get into. His wife had a massive infection, and he did the root canal, and he thought that was going to fix it, but it clearly didn't. She developed a kidney infarction on the meridian. She's a pilot. She can't fly anymore. She has kidney pain. She's trying to figure out what the heck's going on for a year. She's been going to doctors, Cedars-Sinai, everywhere, back and forth. We ended up doing a procedure on the tooth next to it, which had become necrotic from the large lesion. And then we did a surgery where we just enucleated the whole area. We used the laser technique, the PIPs, in the crypt, and it just completely disrupts the biofilm, which I'll show you guys later. And literally the next day, all her kidney pain was gone. So yet to see how she heals, and she's definitely willing to lose the tooth if it comes to that, but she wanted to try to save it, and we were obviously excited to have the opportunity to see if we can heal this and heal her kidney with this type of procedure. Disease is not an entity, but a fluctuating condition of the patient's body, a battle between the substance of disease and the natural self-healing tendencies. We are incredible beings. We all know that. Look at these connections, the nervous system, the meridians, the spirit, the energy, everything. I feel it, and that's how I came to you guys. I had a wake-up call. The universe slapped me in the face. I knew I was supposed to be doing something different, and clearly I am. I'm here. I'm probably the only person doing what I'm doing. But it's pretty awesome. Whenever we have a problem, there's two parts. We got to clean it up, and then we have to rebuild it. Okay. This is a really cool book. One of the examples was a child that got his finger cut off. Any child up to almost 11 or 12 years old, it would grow right back. Meanwhile, you have the allopathic physicians that want to go in for surgery, expensive procedures, when there's a doctor that's no, you just literally let it grow back, and it will. So, again, that's kind of our world. And what's really cool is they basically made an animal model based off these concepts, and they prove without a doubt that it was the electric current that stimulated the regrowth. And they used adult and baby rats, and they were growing entire limbs back. And it was when there was an electric current, that's when the healing happened. So, if we can, why? Well, it's the perception of our world, you guys. Our teeth are a part of this complex neuromuscular system. Just like the last presentation was on sleep apnea, it was a good segue, because I'm going to talk for a few minutes about some of the slides dealing with mastication and this neuromuscular behavior we have. He was talking about tongue position and swallowing and all of this, and when you have that open bite, he was saying to open the airway, you would do this tongue thrust, and also just to get a good seal. I have an open bite, I have an open airway, but I have to stick my tongue forward just to get a good swallow. And I do that 2,000 times a day, and that's a problem. So I'm actually going to be flying to Portland to my guru, who I'll show you in a minute, and he's going to fix my bite, which is awesome. So the tooth and our mouth is the first entrance into the GI tract, okay? This is where we get the nerve innervation for all of these complex processes. So you tap a tooth, you're doing percussion tests. What's happening, okay? What's happening to your muscles of mastication? What are you signaling them to do? Well, they say open, something hard is there, I don't want to bite on that. And chewing speed is so fast, it's only slower to the eye. So when you blink, when something's flying in your eye. And this is the man, Jay Levy. If anyone ever hears him speaking, not Tom Levy, but Jay Levy, he is awesome, brilliant occlusion master. And I'm just so grateful to have him in my life. He's a part of OBI, which I went to with him last year in San Diego. He spoke, it was incredible. There's a meeting October 5th in NYC. Anyone interested in occlusion, these guys know what's up and they're doing it right. And I just was honored to be there. I loved it. So some of the things that he's been teaching me. When you rub your teeth together, okay, everyone take your finger. I want you to just rub it across number 8. Okay? And I know none of you have root canals, so we're good. I'm just going to rub it across. Now, when you can tell where you are on your tooth as you're moving it side to side, that's all pulp. Okay? There's also nerves in the PDL, but those just tell you that something's there. It's not really where is it, how hard is it, it's just either on or off. Okay? So the pulp is extremely important. It does rapidly adapting signals through mechanoreception, okay, and they can turn on and off. It's kind of like whiskers on a cat, okay? He did a whole study on that, and he'll talk to you about it for hours. Okay. The PDL are slow adapting, so like I said, it's just either on or off. You don't really know. But it's the combination of these two things that give teeth this tactile sensibility, which structures the entire, your position that you're walking, that your head's in, you're swallowing, you're breathing, everything, okay? Each tooth has thousands of nerve endings, that use vibration to explore texture and consistency of a meal. So what about them implants? Well, they don't have anything. So as incredible as implants are, and thank God we have them as an option, I really want you guys to think about this. There's no PDL, there's no pulp. There's no signal. There's no signal to the brain. There's no meridian connection there either. I'm talking to different brilliant acupuncturists and people that are in this world, and I'm like, is it better to have an implant or a root canal tooth that's done really well, and you have a PDL and you're getting that blood flow, you're getting that connection? I mean, it's a question to be asked, and I'm hoping to do the research on this in my lifetime here. So, what do these neurofeedback mechanisms do? They're protecting us. They protect our teeth from breaking because they're the hardest substances in the body. All the supporting tissues like the tongue, cheek, and TMJ. If you lose your teeth or even your pulps, you're not going to be able to chew as good. Then you have these large boluses instead of small. You're not absorbing your nutrients. So it's definitely a chain effect, just like he was saying in the last lecture. Imagine moving your jaw to the right. You're chewing. You got your salad. Okay, you're eating healthy. And then something is interfering on the left. It's like you subconsciously shift everything. Your head's moving. And this is how these patients are developing these like chronic facial pains, because thousands of times a day, they're making these movements in their neck and they're messing up the entire muscular system. You can't just move one muscle. They're all connected, okay? And it's the differentiation of complex motion and occlusal function that occurs through spinal segmental inhibitory pathways. So let's move into the PULP-DENTIN complex and how that plays a role. These guys were from the same embryonic origin. They're integrally connected, just like all of us. And when you do something to one, it affects the other. You got all these things in the pulp. And you remember this book, Tiffany? Mior. I came across this book like a couple of weeks ago, and I was like, oh, the Holy Grail. I'm like, wow, this is exactly what I need. It was really funny. This guy was hilarious, and he was a teacher at the University of Florida. So here's just like a histological slide. This was in the paper that I wrote just as a reference. It's like, here's your dentin, you got your pre-dentin, you got your adenoblastic layer laying down the dentin. Cell-free zone, that's a CF, that's like where there's tons of vasculature. And then you have your cell-rich zone, and that's like your fibroblasts and your dendritic cells and things that are kind of looking for issues. So you have some dentin exposure, whether it's you scaling, scraping on the tooth, caries, just spontaneously want to drill in the tooth, whatever the situation is. You're going to get movement in the tubules, you get a rise in tissue pressure, and then the nerves start to activate, and you get pain. The fluid flow is dependent on the conductivity inside that tubule. And you can get mineralization of that in tons of ways. You can get it from the peritubular dentin kind of enclosing in. You can get it from other mineral precipitation, or if you get minerals coming in from the outer surface of the dentin. It's all possible to kind of slow it down and decrease pain. We do that all the time, right? What else is in the PULP-DENTIN complex? We've got arterioles, venules, lymphatics, really, really thin-walled ones, but they're all there. They enter and leave through the foramen and all the little lateral canals. There's a ton of capillaries that aren't even like functioning. They're just hanging out and they're just waiting. They're like on standby. As soon as there's inflammation, they upregulate and all start functioning. And those capillaries, they're basically lined with fenestrations or just openings so that stuff can kind of come in and out. So more than in a normal endothelial area. This facilitates exchange of nutrients and waste products. And it's really important during trauma or inflammation, right? We've got two types of nerve. We got our somatic afferent, and then you have your sympathetic efferent nerves. Okay, so the afferent are obviously, they're telling you what's going on at the scene. Your A delta and A beta in the pulp are just like letting you know if there's those tissue movements. Unmyelinated C fibers, those are really like a painful nerve. Those things can live in like the nastiest of necrotic teeth. These C fibers have been shown to just survive. So whether that's maybe something good for us down the road, I don't know, but they're there. And they're releasing all of these substances like neurokinin A, substance P, CGR. P as well. And then the sympathetic, while the afferent kind of signal vasodilation when there's inflammation, the sympathetic are also actually doing the opposite. They're creating vasoconstriction, decreases the excitability of the nerves. So when you have a tooth that's dying, you go to do a cold test, always do the teeth around it or a contralateral tooth first. I hope everyone knows that. So you can actually get like a sort of a baseline. So you're testing 18, feels cold right away, goes away. 19, got your endo ice on there. Oh, I feel it. Okay, I feel something. Okay, now it's hurting a little bit. Those are your C fibers, okay? What's really cool that I learned in this book recently is that, and it makes sense, like I see it, but when you're probing around a tooth that's already inflamed, it's like really hurting more than another tooth that's not. So just by irritating the periodontal ligament, you're kind of creating more blood flow to that area, that tooth can start hurting if there's a pulpal issue. So basically when you have this thing happening, trauma, caries, whatever, there's, different levels of reactions. You can get a slight one where you're just starting to kind of get some cells coming in. You can get moderate where PMNs are really being upregulated, and then you can get severe, okay? So this is a histological slide of just showing you like what a dendritic cell's doing. He's hanging out, just floating in this river here of the cell-rich zone. And he picks up an antigen, brings it to your lymph area, and the T cells get activated and they know what to do. So there's different forms of dentin that happens after these signals, right? You've got your primary dentin, that forms when your teeth are developing. Then you have your secondary dentin, which is just kind of this slow process that just always happens. Our pulps are just kind of gently shrinking away. And then tertiary dentin is a little more direct and quick and local. And you can either have reactionary or reparative. So reactionary is like there's a cavity, it's coming in, we're prepared, we're making moves. Odontoblasts are laying down dentin. Your reparative is when it's happening so fast that the odontoblasts die. So then stem cells that you already have just hanging out, waiting, move in, and they become new odontoblasts or similar. So here's a schematic of that. Odontoblasts, talking, hanging, moving, new dentin. Here they just died. So then you see these are your stem cells and they kind of move in and they differentiate. Our bodies are brilliant. Okay, so let's get into regenerative stuff. Why do we want to do it? Well, proper mechanoreception, right? Very important. I think more important than any of us really get, but I think maybe one day we will. Obviously, we want to be able to fight off infection and bacteria. Vital pulps and vital tissue are key components of the immune system. And lastly, this energetic thing. We want to keep those currents flowing. So the AAE is on board. Okay, they've been doing these regenerative procedures for a very long time. When I was in my residency, it was like, yeah, we're doing revascularization. Like, what's up? It was cool. I mean, I'm in my residency, we're bringing teeth back to life. That's why I went up to Don. I was like, you see what we're doing? So I'm going to show you guys some cool cases, but basically biologically based procedures designed to physiologically replace damaged tooth structures, including dentin and root structures, as well as the pulp-dentin complex. So, requirements for these type of procedures, okay? Proper case selection, key. Atraumatic cavity preparation, another key. Aseptic environment, so important in endodontics. I mean, that's like our holy grail is like rubber dam. They don't even know about ozone. I'm gonna let them know, you guys don't worry. Proper materials, tissue management, proper occlusal forces, mastication, and those forces that are going on these teeth are like probably the most important thing after your procedures to look at. And of course, long-term periodontal health. You know, if I can sterilize the inside of the tooth, can you guys guarantee me that this patient's gonna learn how to brush their teeth properly? And when I went and saw Jay in Portland, he taught me how to brush my teeth a few weeks ago. And I was like, oh, all right. I was like, that hurts, Jay. He's like, do it. Okay, so it was pretty interesting. He takes the time with all of his patients, and I think a little more aggressively than I do, and that we probably tell our patients is like getting these things cleaned. And these abfractions and this recession, it's from occlusion. Like 99% of the time it's from occlusion. Determination of pulpal structures, that's not a quote, by the way, that's just like me throwing out a number. I have no research to back up that number. Determination of pulpal status in cariously involved teeth. Okay, so is this tooth hurting them? Like, are they coming in like, this thing's been killing me for a month, I'm sorry, I just haven't had time to come in. May not be a good candidate to try some of these procedures that we're going to talk about. Obviously, you have to look at the tooth. You got to look at the x-rays. You have to do your proper testing. It's kind of crazy what I get referred sometimes. I'm just like, aren't you a dentist? Like, don't you know what's going on here? But again, just taking your time, really kind of thinking about the situation, making sure it's not occlusion that's setting them off, making sure the tooth is salvageable, and also like the size and the appearance, if you do have exposures, and dealing with the pulp is very crucial, and I'll talk to you guys a little bit more about that. All right, so here's where the protocols are. And like I said, I'm happy to send you guys this because this is going to be a lot to just read through, but I'm going to just kind of talk about it. So I had a patient come in with like totally asymptomatic, just decay near pulp. You know, just went in and cleaned it up. Did I? Yeah, I put the picture of the following X-ray after the restoration. So when are you going to do this? When you have decay that you think you can, you know, not go into the pulp, or you're one of these people that wants to do the two-step, where you go in, you remove the decay, almost all of it, whether you ozonate it or just place your medication or whatever you're doing, and then you go back in months later. I personally don't want to drill on that tooth twice, so I try to do everything as much as I can in one visit, except large lesions, calcium hydroxide for sure, long term. Okay, but something like this, like I don't want to traumatize that vital pulp twice by drilling. Contraindications, let's see if there's any more. So like, yeah, just mainly the pain. And if like you're going in and the decay is like so soft and gooey, it's like, just keep going. Don't stop, in my opinion. Ozone is incredible for that, and we'll talk about it a little bit. Yeah. So with ozone, I don't really have one. Before ozone, like 18 younger kid type thing. The ozone is so incredible, and there's a specific technique. Like as you're getting closer, and I think I have this all written in here, it's so crucial, you guys, that you have this aseptic environment, right? So you have your rubber dam on, there's no saliva coming in. You start removing the decay on the external surface. Literally have sterile burrs ready for you. No one touched with their fingers or with their gloves. You grab it with cotton pliers, and I in a series of these burrs, I get closer and closer. Now, if you're using a laser, which I'm doing now, to remove decay, it's incredible because the photons are just obliterating the structure completely atraumatically to the pulp. They don't even have to be numb a lot of the time. It's crazy, and it's sterilizing as it goes, so that's really cool. But when you're using the drill and like your round burr or whatever, just make sure you have like 10 of them out, and it's like literally every 10 seconds. Like I just use it, change it. So you're not introducing this external bacteria down on the pulp, okay? That's huge. So if you can do that, and then if you're using ozone, I mean, I'm just blasting that pulp. You can just see it. It starts to just create this like nice dark color. It's not bleeding. And I feel more than fine on any person capping that if it's done properly. So here's just the example of the indirect. So we removed everything. I ozonated the heck out of it that means probably about like 2 minutes, okay? And then I placed a little liner of my bioceramic material followed by composite. So how is what I'm calling bioendo, which is what we're doing? You're all preventative endodontists, whether you like it or not. You're all of you. Because we're dealing with the nerve, right? So bioendo, how is it different? Well, as you can see, ozone. There's this guy named Carlos Nogales. He's this awesome endodontist in Brazil. He's doing tons of ozone research. And what he's kind of figured out is that 40 micrograms per milliliter is a good concentration to use for caries. And he really was looking at in the canals, right? But he was looking at how that gas level affected fibroblasts, which are key. So he found that 40 was able to kill all the bacteria. It did irritate the fibroblasts a little bit, but after a couple of days, like 72 hours, those things were like stronger than ever. They were better than lower concentrations of ozone. So that's the magic number, is 40 for cavities and this type of thing. And I don't want to desiccate the tubules, right? So I'll do a little ozone, I'll rinse with a little water, ozone water, kind of go back and forth. And I'll do that for like 2 minutes. Place my base material, which is usually like a bioceramic composite, really nice composite, good margins. And that's when we get into some fun integrative stuff. And I'm loving it, and I'm learning a lot at Phil's course, and you guys could too. Ozone injections. I'd love to get some more blood flow into that tooth in the apical area. So I'd back it up with that. And I'd maybe do it every 3 months or so, or if the patient's kind of feeling better, but maybe a tiny bit sensitive, I'd bring them back in. Homeopathics, I'll get into it a little bit, but like lymphomyoside, let's drain some of that lymph out of there, let's help the body along. Trameal for inflammation. And there's some other ones. Dr. John over here told me about PULP-DENTIN out of Germany, and it's basically a homeopathic to help heal the nerve tissue itself. So I'm using these kind of triage of stuff, along with this, all these letters right here. What's that? That's photobiomodulation, low-level laser therapy. You can all get this low-level laser. It's not like necessarily this crazy investment. You can get one for pretty inexpensive. And just by shooting photons, light energy, into the body, we're upregulating stem cells. It does a lot of the same things that ozone does. So it's like, wow, what about the two together? That, again, is where I'm going to do a lot of research, so look out for that in the future. But incredible results. I've had a ton of patients where I'm not doing root canals. I'm trying not to do root canals. Even though I get paid way more when I do it, I'm not doing it. And I'm trying to save these teeth. And obviously occlusion, again. So here's the ozone. Longevity is awesome because it has the foot pedal. So I have that in one of my offices. Got this guy in the other. No foot pedal, but still awesome. This is like the heel ozone handpiece. I think that is probably like the most effective, getting like a suction cup situation over the tooth, right? I use this a lot too, though, just the Salvin handpiece with like an etch tip or something, and I'm just kind of going back and forth. And you can see the tooth just crystallize right before your eyes. You see it get clean. I've also used it with some internal bleaching cases. It's going to eliminate bacteria. It's going to increase your fibroblast viability, okay? Increase ATP in the mitochondria, and just overall like healing, nitric oxide, getting blood to the area, letting our body do its thing. Okay, so what's the difference between what we just did in direct pulp cap? Well, obviously the pulp is exposed, so we're going to be very, very careful about introducing bacteria. We're going to be very specific in where we're placing the ozone right over that pulp tissue. I may need another water. Just throwing that out there. Okay. So let's see here. When you're going to do a direct pulp cap and not an indirect, well, obviously if the decay is going in, and we're going to call a direct pulp cap like whether it's just the tip of the iceberg or whether it's like you're doing a pulpotomy essentially. So I have a case I'll show you guys. We're doing some of this stuff at UCLA. They're not even using ozone yet. Like I'm just like slowly working on them. But they're doing cases with just using sodium hypochlorite or chlorhexidine or even Paradex, and irrigating the inside of these canals, sealing them off with these bioceramics, like removing the entire coronal pulp, and you're seeing healing around these teeth. So I'll show you guys some of that in a little bit. But the key difference in direct pulp cap is you're dealing with the actual pulp, so you want to be really careful there, right? So according to the AAE guidelines, visit 1, you want to make sure that you have a radiopaque material. Why? Well, your patient moves, they go to another dentist. Look, you have a cavity right over your pulp. Well, it's like, no, that's a radiolucent material. And that's some of the problems we had with like Endocal and some of those obturation materials you've seen in the past that are supposed to be like biocalyx, are supposed to be healthier, but you can't see them. So it really makes a difference if the patient's not educated. If the patient's educated, that can work. Thank you so much, Eric. Okay, so you place your base material. I'll play these little videos. They're just real short, but just to kind of see, this is just kind of irrigating the exposure. I mean, that's a healthy pulp. I don't see any bleeding, but if you start poking it, it will bleed, okay? Healthy pulp looks like almost like cooked spaghetti, and then you start manipulating it, things start changing, and this is how the MTA was placed, okay? It's a tough material, MTA. It's just straight dry powder. The best way to prepare it, if you guys are gonna do a pulp cap, if you're using like the traditional MTA, put a drop or two of like ozone water, like literally 1 drop, because it will just soak the cement. So you want it to be, I don't want to say IRA, but it's just kind of like this doughy consistency that you can manipulate it just a little bit, and you just like gently tap it in, okay? And you can take cotton if you want and just kind of dab it. Just make sure that no cotton fibrils are left, because that could definitely be a source of chronic inflammation, and that's where the microscope is key. I hope that you guys are all using like high-powered loops if you're doing anything near the pulp. I can't even tell you how many times I've seen like a little like fibril from like a scrub or something just like land on a tooth. I'm like, get this out of here. So what you guys can't see like will hurt your patients. So this is the case. I mean, look at this massive cavity, and this was featured in the article. This is by Dr. Lim, who's an awesome endodontist in LA. And he basically, high speed, he used chlorhexidine, got all of the pulp out, but you can see it just looks so nice. Like that's the remnant, that's the pulp stump, okay, in the orifice. Place the bioceramic material, which Brasseler makes, and it's a lot easier to use than the MTA, and results are looking good for studies. But it's like flowable syringe, just like float it on there. Top that off with some like glass ionomer, maybe like Fuji 2LC. That way you can do a nice etch bond composite. You cannot bond directly right on top of these bioceramics or the MTA. It'll wash right away, okay? So here's the recall, which is pretty cool. So you can see before these wide open apices, and then you see now. Now, I know what you guys are thinking. I still see a little darkness now, but look at this guy right here. It's still growing, so give it time. Okay, that tooth's fine. These are a bunch of cases, so it's not just the one. Just giant apices, deep decay, cleaned properly, and they're not even using ozone in these cases. So I'm telling you guys, we have a chance, okay? And look at this healing that you're getting. Really cool. So these are all vital pulp therapy cases. That could be an indirect pulp cap, it could be a direct pulp cap, it could be a pulpotomy. We're dealing with vital pulp. We're trying to keep it that way. So your outcome depends on the material you use. You don't want to use Dical. Sorry, that ship has sailed. No more Dical. Okay? Get the bioceramic. Thank you so much, Don. Get the bioceramic from Brasseler. So easy. And also, Ultradent now is made like this MTA that you can mix to whatever consistency you want. They give you these flowable syringes. A little messy, I'm not going to lie, but I'm liking it. I'll talk to you about that a little bit more later. I'll show you guys a picture. Let's see, anything. Obviously, the age of the patient, like you brought up, it does help. I mean, if you're young, you're going to heal a little better. But when we blast the lasers and the ozone, and when we put all of these things together, I'm seeing a lot of success, and even just like older people, it's really awesome. So periodontal occlusion. I don't know how much you guys know about occlusion. I'm just getting started in this with Dr. Levy, but I don't know how many patients you see with this perfect canine lateral excursion guidance, but like nobody. I don't have it. All Dr. Levy's patients have it. I want it. This is where your teeth should hit when you just bite together. And then when you do excursions, you need to make sure you're clearing those. Now, there's different ways to do it. You can grind away at it, which a lot of us do. If it's one tooth, okay, but if you're equilibrating an entire mouth, his philosophy is a little different. It's like, how about we get the joint where it's supposed to be and then move the teeth to that? Really smart. These guys at OBI, I'm telling you, they're awesome. Now, it may take a long time, but it's like you do it the right way. And there's a lot of really cool, like, one-day stuff, too. I've seen it. I mean, these guys are good. They're getting joints in very close to proper positions using 3D CT scans integrated with their CEREC machines. It's awesome. I'm going to go observe a case in a couple of weeks, actually. So I'm learning. We all should be. Occlusion. So these are some of the homeopathics. This is me working late. It's dark outside. Too often I'm helping too many friends, but I get to experiment on them, so it's cool. Lymphomyosat, Procaine, awesome. Gets to like just kind of reset some of those areas of scar tissue, and some homeopathics. And Phil taught me how to do, is Phil here? I keep dropping his name, he's not even here. How bad is that? Okay, so the wand, awesome, right? Go in the PDL, and you can do single tooth anesthesia. He showed me just take these homeopathics and you just inject it right back in like a normal carpule, like a normal lidocaine. I dump that, put it right back in. He already knows. And then you load it in the wand and you like get to just infuse these homeopathics around the PDL. Very, very effective. I have to throw this out there. I've never used this. I don't know much about it, but the incredible periodontist I'm working with, we were doing a little like after hour CE online together. Hugh Freedy has this new thing. Seems right up our alley. They're shooting glycine, amino acid, powder around the sulcus, and like some of these videos, like plaque, biofilm, everything was just wiped off these teeth in seconds. You guys, seconds. Look at curettes. This is not doing what you want it to do. It's not removing the biofilm. Yes, if you're using ozone with it, okay, great, but you're not effectively removing that stuff, and you're tearing off our really crucial layers of teeth that are protecting our tubules. So think about it. This is my laser. I thought I was good, but the glycine got me. So Hugh Freedy. No affiliations, I'm just sharing knowledge. So this is the new MTA from Ultradent. You like mix it, they give you a little card for this, you do this, 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 this. You load it in these syringes. Really cool because I'm actually putting this tip from Ultradent on the syringe, and I have injected entire teeth with MTA after I've done a root canal. Okay, so liquid MTA, filling the tooth, laser activated, this stuff just goes everywhere. Okay, it's a mess to clean up in the chamber, but we'll deal with that. So revascularization, the really cool stuff that, to be honest, like, and we've been doing this for like 15 years, so I'm surprised not more of you guys know about it, but maybe you do, I don't know, let's see. So indications, necrotic tooth, like you saw in the very beginning, giant lesion, okay? The key for endodontists and for the AAE is you have to have an open apex. It has to be immature. So you have an immature apex, the number I remember is like a millimeter, which is a size 100 file, which is enormous. So what, if you have that, it's like, why do you want to save that tooth, or why do you want to try to pack MTA down there? The walls are like paper thin, it just doesn't make sense. So someone, Dr. Trope, a famous endodontist, he's like, let's have some fun here, let's bring these teeth back to life. And it worked. So we have the fountain of youth. So just to talk you through it, large infection. I don't know what happened with this case, like trauma. I don't recall the details, but you could maybe just get a little cavity in the occlusal of a premolar, and the pulp's so freaking big in these kids that the bacteria just got in. Sometimes in lateral incisors, maxillary lateral incisors, see those deep lingual grooves. Those things are like a nightmare. Those harbor bacteria, and you see a lot of lesions on these laterals. You're like, why did this happen? Look kind of under the tissue, and you'll see these deep dark grooves. 8 minutes. Oh, it's time. It's over, you guys. Look, they're all like hanging on the edge of their seats. Okay, so let me just finish the revascularization because that's why we're here. So visit 1, drill through. Here you go ahead and place classically a triple antibiotic paste. You could use calcium hydroxide. They had some issues with staining with minocycline, so they're just still like they're using 2 antibiotics now. 1 month, you place Cavit, okay? Cotton and then Cavit. So antibiotics, like you just get it from the pharmacy, mix it with water, put it in the canal, temporary. come back. You're seeing healing. You flush out the medication. They're just using like a needle irrigation. I have like the most incredible laser technique. And then put MTA down. And this is like an 18-month recall. I mean, that tooth's back. Root completely closed. The PDL's healing. Okay? So now this person got to save that tooth. I mean, that is incredible. I guess that's where we should end it.